So coming to the next nerve, the seventh nerve, this is again mixed type of nerve. This is important nerve called as facial nerve. Uh, so this is nerve of the second branchial arch or branchial cleft. You can see this is nerve of smiling. It is supplying to the muscles of facial expression. So that's I have told 2 2 4 4. So this is forming a part of forebrain, midbrain, pons. So this arising from the pons. You can see this is midbrain, pons, medulla. So from this pons there are four. On midbrain 2 nerves, and medulla oblongata 4 nerves, and 2 are the from forebrain. So olfactory optic, and 2 from olfactory oculomotor trochlear. 4 are olfactory optic oculomotor trochlear trigeminal. 4 abducent. 7th facial, and 8th is vestibulocochlear. So facial and vestibulocochlear, it has to be very close to each other. So now remain is 9, 10, 11, 12. We have seen accessory, hypoglossal, vagus, glossopharyngeal. So like this, 2, 2, 4, 4. Cerebropontine. This is one of the question. Just now I have shown you facial, this facial nerve and vestibulocochlear. They are very close. They are arising from cerebropontine angle. Most cranial effect in the facial nerve, vestibulocochlear. Getapetrosal nerve. Now what happens? So if you see this, the black color is the motor root, and very thin part is the sensory. So facial nerve has got a long root. Again, it comes out and passes from interacoustic meatus. This is the petrous bone. This much course is in the petrous bone. Long course, D, C, B, A, up to A, B, C, D. This much is inside the bone. You can see here. This is A, B, C, D. So this part, this course is inside the bone. So where it is inside, it enters from the internal auditory meatus, then in the facial canal of petrous temporal, medial wall of the agusa. So this is petrous temporal bone. Facial nerve is passing from petrous temporal, internal auditory meatus. Then it traverses this course. So this course is totally, D is internal auditory meatus, and this is, where is this, Y is a C, Y is a B. So these are different branches which is arising. Just if you notice this, A is exit. It is just like a tunnel. It is coming out of the tunnel. This is A is the exit of facial nerve, and D is the entry. So this is internal auditory meatus. From there, C and B are the important locations inside the tunnel where it is giving the two branches. So it comes out of cerebropontine angle, goes inside the internal auditory meatus. Here is one important geniculate ganglion is there. Before passing to geniculate ganglion, it gives a branch called as GP, greater petrosal nerve, which passes through pterygoid canal to pterygopalatine, PG. GP is greater petrosal, PG is pterygopalatine, and then going to LG. PG, GP, greater petrosal, PG, LG, lacrimal gland. Just try to remember this sequence. Most of the questions are for lacrimal gland to the eye, supplied by facial nerve through its sensory route, and before going through geniculate ganglion. So any injury at this geniculate ganglion will spare this action of. Then it goes inside this petrous bone. This is the bone. Inside this bone, you can say this is geniculate ganglion, and this one is the thin nerve is GP. So even though it is this is coming inside, this is internal acoustic meatus. It is coming it, and this is one greater petrosal nerve going to pterygopalatine ganglion to the lacrimal gland. Then it passes through the geniculate ganglion, and here it gives a very small branch. You can see this is the small branch from the bone, and you can see if you go deep into this is the middle ear and this is the cavity. This is the stipes like this. Incus, malleus, and stapes. These are the bones of the ear inside. So it is supplying a nerve to stapes. So what the stapes is doing? Stapes, you can see nerve to stapedius. This is the muscle which is given to the stapes. Very small stapes bone is there. To that stapes muscle is doing the movement. So the function of this stapedius muscle is whenever the sound waves are hitting to the eardrum, it is transmitted through the auricles, through the stapes to the inside the nerves of the ear. So it is dampening the sound. So any nerve damage, any loss of this, the person gets hyperacusia. So that is nerve to stapes. Then before coming out at the B point, this B point, another important, very important sensory nerve called as chorda tympani. The name is chorda tympani. It's a misnomer. It has nothing to do with the ear, but it is supplying to the anterior two-thirds of the tongue along with the lingual nerve. So lingual nerve, which has to be carrying taste sensation, chorda tympani, a nerve which was misnamed. Why? Because this is while passing the course. This is chorda tympani. It is passing from the chorda. Chorda means this is supposed to be the eardrum. Whenever anything passes from the center is the diameter. Anything chord is anything passes not from the center is called as chord. So this name has come because it is just like a chord, and tympani is the tympanic membrane. So it is passing like this and passing from the pars flaccida. So this is tympanic membrane or eardrum, and it is passing from this above, and that is upper part is pars flaccida and lower part is pars. This is pars flaccida and this is pars tensa. So this is the handle of incus, and all this we will see in the eardrum. So chorda tympani, this nerve is passing from the ear inside and coming out and getting a long course. Along with this, it is supplying here with the lingual nerve. This is the lingual nerve and supplying to the tongue. Here is this chorda tympani, lingual nerve, a big lingual nerve supplying tongue and giving branches to submandibular and sublingual glands. Then it comes out of the original stylomastoid foramina. This is the exit from here when it comes out of stylomastoid. So you can see inside the facial canal, it is supplying nerve to stapedius. Injury causes hyperacusis. One question, it is supplying through chorda tympani, and it chorda tympani exits from chorda tympani, pterygopalatine fissure. So exit this. This is a small exit for the pterygopalatine, PT, pterygopalatine fissure, a small exit of chorda tympani. So this is just like a canals inside, going inside to the internal acoustic meatus. Then from there, one nerve is coming out, GP, greater petrosal nerve, supplying pterygopalatine ganglion, greater petrosal, and another which is very small nerve passing from the to the stapedius, and it is stopping here only to stapedius. This nerve, another chorda tympani, is passing inside the ear, coming out through pterygopalatine fissure, and it is supplying to the tongue. So this is another question. Then if you see facial nerve exit from the skull, final exit is from the stylomastoid foramen. Stylomastoid, the name itself is giving in between. If you see here is I think this is styloid process, and this is mastoid process. In between styloid and mastoid, this is foramen, so that is called as stylomastoid foramina. And this styloid process has got a muscle called as stylohyoid muscle. Hyoid bone is somewhere here, so it's stylohyoid, and this is another digastric muscle for the tongue. So when it is exiting at this foramina, it is again giving, you can see here in this is the exit, this is the styloid process, so it is supplying to nerve to stylohyoid, then it is supplying branches posteriorly to occipitalis, nerve to posterior digastric and occipitalis. So these are the nerves. Sensory is posterior auricular is a sensory. Again, this is important. Posterior auricular nerve, occipital. Okay, then it comes out of stylomastoid foramina, styloid process, enters into the parotid gland to give terminal branches. These are 5 terminal branches: temporal, zygomatic, buccal, mandibular, and cervical. These are motor branches, not sensory. Buccal was actually sensory. Buccal branch was by the trigeminal. These are motor branches. Motor branches, why it is required? So it is supplying to the muscles of the face. These are all motor branches. You can see pink color is temporal branches supplying to frontalis, orbiculis oculi, and corriga. Means this, what the function of orbiculis oculi? Closing the eye. Corrugator supercilii, this is frowning. Frontalis, again lifting of the eyebrow and upper front. So this is the muscle branch. Any injury, lower motor paralysis, will lead to loss of this motor function of the facial nerve. That's why closing of the eye, frowning, all these tests are done. Orbiculus oculi, zygomatic branch. Again orbiculus oculi, orbiculus oculi. For closure of the eye, there are 2 nerves from here, temporalis branch as well as zygomatic branch. For closure of the mouth, orbicularis oris, buccinator, blowing, zygomaticus, the buccal branch. For marginal mandibular branch, so depression, label inferis, means angle of the mouth is depressed, so this is marginal mandibular branch. Angular oris, again this is lower lip depression, this is angle of the mouth depression. And mentalis, all these are the muscles. And cervical branch is supplying to platysma. Platysma is a thin strap muscles of the neck. So you can see cervical branch, red color, blue branch margin mandibular, green color is buccal, auriculus, angle of the mouth. These are the muscular branches. So terminal. How to test? Now immediately if you understood this of the supply, sensory as well as motor supply of the facial nerve, you will be able to understand upper and lower motor neuron paralysis. Upper motor, here is the upper motor, this is the motor function. You can see this is the brain, there is the cerebral cortex. Now if you see the motor cortex, the frontalis and upper muscles, they are crossing on this side and this side, opposite side, as well as some are on the same side. So there is cross supply to upper part, while the lower part is having only crossed. So anywhere damage upper motor neuron lesion, if suppose you can see here the blue color is intact and brown color is damaged, so brown color is supplying only to the contralateral lower face. So contralateral lower face muscle actions will be lost. So what is this? This is the angle of the mouth is depressed, then the loss of nasolabial fold. Only this much part. Upper motor neuron paralysis, there will be less sign, while lower motor has got more sign, because this blue color cross is again supplying upper face has got dual supply from same as well as the opposite sides. So this main trunk, both the sides are crossed, so a person is unable to wrinkle the forehead, lift the eyebrows, and eyelids are drooping, and he cannot close the eye, unable to close, but it is little bit drooping. So further symptoms: decreased lacrimation, impaired sense of taste, anterior two-thirds of the tongue, chorda tympani and pterygopalatine. So this is about upper and lower motor neuron palsy. And this is about the eighth nerve, coming after 8th and 10th nerve. Glossopharyngeal, sorry, ninth and 10th nerve. 8th is vestibulocochlear. Ninth, glossopharyngeal. This ninth nerve is the nerve of swallow, and vagus is for speak. Because superior laryngeal and inferior laryngeal are supplying to the vocal cords, and glossopharyngeal for the palate and all that, swallowing and all that. So it carries a taste sensation from posterior. Anterior two-thirds was done by already by the chorda tympani of the facial nerve. So posterior one-third, taste as gentle sensation is by the glossopharyngeal. This is one question. Second question is regarding, it is supplying the baroreceptors. It is carrying the sensation from the carotid body, which is called as baroreceptors for level of partial pressure of oxygen and all that. Then lesser petrocell to otic ganglion. Greater petrocell was gone to pterygopalatine ganglion. This is lesser petrocell to otic ganglion in parotid gland. That is parasympathetic. Motor supply to stylopharyngeus, muscle of the pharynx. So glossopharyngeal is the pharynx. Stylopharyngeus, it is for the muscles of deglutition. Now, if you see, compare it with the vagus, it is supplying to larynx, pharynx, esophagus. Vagus is a very long supply to GIT, to the larynx, to the pharynx, external acoustic meatus, carotid, and aortic arch. So these are again baroreceptors. Baroreceptors, aortic and carotid arch is different. Carotid body is sinus, and sinus is different. So thoracic and abdominal viscera, two-third of the transverse colon. So up to right side two-third of the transverse colon. This is up to midgut. Okay, up to midgut. Vagus is supplying up to midgut. The larynx, pharynx, esophagus, and palate. So if you see, this is about the gag reflex. The question is again for this. You touch the uvula, you get some vomiting sensation. So afferent is by the glossopharyngeal and efferent by the vagus nerve. The same thing is for the cough reflex. Whenever some irritant is there in the mucosa, the person gets a cough. The center is medulla, and afferent is vagus, and efferent is same vagus. Now these are the different cranial reflexes. If you just try to remember, light reflex is carrying through the cornea. This is light, not touch. So afferent is same, second nerve. Cornea reflex is touch sensation, is by the trigeminal nerve, while light and near and distance vision, this is for the vision. And efferent is same, three nerve for light as well as near vision. Third is the trochlear, olfactory, oculomotor. Third, lever palpebri superior is blinking of the eye. You put a torch in front of the eye, suddenly eye is blinking. That is called as light reflex. You touch the cornea with a cotton. So a person then closes the eye. Blinking and totally closing the eye is different. So seventh nerve is orbicularis oculi. Facial nerve has got supply. Sensation is carried through the trigeminal nerve. The gag, you are touching the uvula, sensation is carried through glossopharyngeal, and the vomiting movement or something movement, this is done by the 10th nerve. The cough is sensation is carried by 10th, and motor action is by again 10th. If you try to remember the nuclei, each nerve has got some nuclei inside the brain, midbrain, pons, medulla, or somewhere. Third nerve nucleus is Edinger-Westphal. Motor nucleus and nerve is oculomotor. Ganglion is ciliary. It is causing constriction. constrictor pupillary and ciliary. So whenever there is injury, damage to this, there is pupillary dilatation. Okay, the brain injury is there, nerve injury is there, you get a blown out pupil. Then facial nerve, its nucleus is superior salivatory, face salivatory, glossopharyngeal, inferior salivatory. Now facial nerve has got upper is greater petrosal passing through pterygopalatine, GP, PG, LG. Greater petrosal, pterygopalatine, lacrimal gland. Chorda tympani, taste sensation passing to the eardrum, near the eardrum, but supplying going through submandibular gland supplying to supply to submandibular and subsequent gland. Then inferior salivatory, the greater petrosal, this is glossopharyngeal inferior otic ganglion to parotid gland. So important glands are lacrimal gland by the facial, submandibular sublingual gland by again facial, and glossopharyngeal, the parotid gland by glossopharyngeal. So origin of cranial nerves in the brain, this I already told. 244 midbrain, third nerve and fourth nerve, and pons fifth, sixth, seventh, eighth, seventh and eighth from the cerebropontine angle, medulla 9, 10th, 11, 12. If you see cranial nuclei in the brainstem, this is a little bit confusing. We have just read about Edinger-Westphal nucleus. These are the all nuclei. If you have got time, pause this and read about the nuclei. 244 midbrain, pons, medulla. So coming to foramen of base of the skull, olfactory, optic, superior orbital fissure, third, fourth, fifth, sixth nerve, fifth division 1. I have told about this trigeminal nuclei, ophthalmic, maxillary, mandibular. Then you can see rotundum, oval, the nerves which is passing we have seen. If you go down and see important optic canal, so this orbital feature is different and optic canal. So optic nerve is passing through optic canal. Here is the optic canal. Immediately the second foramina after cerebral plate, there is optic canal. One is optic nerve, important. Then ophthalmic artery. Ophthalmic artery, the question is, it is internal carotid, first branch of the internal carotid artery. So it is inside. Internal carotid has come inside the brain above. From here, first branch is going directly to the eye. So this is internal carotid artery. This is the optic canal. So close by, yeah, there has to be a branch. Internal carotid artery, like this, there is a branch. Then superior orbital fissure. This is just like a fissure, long fissure. So third, fourth, fifth, sixth also. Fifth means that is ophthalmic nerve V1 division, and ophthalmic vein is passing along with this. Artery is passing from the optic along with the optic nerve, and vein is passing from the orbital fissure. So these are from the eyeball upper part. Now there is foramen rotundum, maxillary rotamax, foramen oval, mandibular we have already seen. So this is foramen oval, OVALE, mnemonic to remember, otic ganglion, which is for the parotid gland. Then accessory meningeal artery, lesser petrosal. Again, lesser petrosal, otic ganglion, same emissary vein. So if questions are asked regarding mandibular nerve, foramen oval, mandibular. This is again important question is asked. Middle meningeal artery is passing from foramen spinosum. So if you see, it is a branch of external carotid artery. Here you have got internal carotid. Now if you see location of foramen spinosum, this, how to remember this? Sometimes you get a lot of confusion. So just you, if you see internal carotid artery and foramen spinosum, this is foramen spinosum. This common carotid artery divides into external internal, and the external this middle meningeal artery. If you see the branches of external carotid artery, now this is important. If you understand it like this, it will be easy to remember the things, because internal carotid artery, it goes inside the brain and gives first branch, that is ophthalmic artery. While external carotid artery, if you see, this is external carotid artery. It has got anterior 1, 2, 3, 4 branch. Internal carotid artery is arising, this middle meningeal artery is arising as a branch from maxillary artery. You see here, this is maxillary. This is continuing above as a superficial temporal. So here it has to be somewhere internal carotid artery. This middle meningeal artery. Why middle meningeal artery is important? It has got relation with the foramen. It is a branch from external carotid, maxillary, then it passes to foramen spinosum. Here is again middle meningeal artery. This is inside the brain. So this is foramen spinosum. It is passing and above like this. So if you see this foramen, this is somewhere foramen spinosum, it has gone and it is going on the surface, inner surface of the skull. So any injury related to anterior branch of this pterion is a anterior branch, this is posterior branch. It causes injury, extradural hemorrhage. Most of the time extradural hemorrhage because of injury to the anterior branch of middle meningeal artery, which is coming inside from the foramen spinosum, which is a branch from one of the branch of external carotid artery. And I will confirm, is this a branch from maxillary or something? Now foramen spinosum, the important is middle meningeal artery. Then important is, another important part is foramen lacerum. A big foramen is there. You can call it as a foramen. This is foramen lacerum. You see, it is instead of foramen, there is some just like a plate is there, and he is the. So I have already internal carotid artery is the main content. Inferior part is closed by phycardia. Superior part transmits the internal carotid artery. This is like this. Internal carotid artery is going inside and transmits and great and deep petrosal nerve. Great and deep petrosal. Greater G8 and deep petrosal. So fibrocartilage, this is the internal carotid artery. It comes out here, and here it gives the anterior cerebral and middle cerebral, and here the circle of Willis is formed like this. So two internal carotid arteries from two sides, they form the circle of Willis. From posterior side there is basilar artery, they form the circle of Willis. So you have to understand the base of skull, foramen lacerum, internal carotid artery is very close. This is foramen oval, all these foramen. Then these are another foramen behind, large jugular foramina. This is basically for the veins. This important artery is coming from the anteriorly, and important vein is from the posterior side. The rest of the nerves which we have seen, this internal acoustic meatus is like this. So facial nerve, from here if you start, again if you want to revise the nerves, you can see on this side up to fifth, here it was there. This is the internal acoustic meatus, facial nerve has passed inside, along with this facial and eighth nerve is there. Now remaining after eighth nerve, this is the petrous, now petrous temporal bone. So carotid canal, just now internal carotid artery we have seen here, foramen lacerum and internal petrous, internal carotid artery. Transmit the foramen lacerum, then it enters into parietal, deep petrosal, sympathetic plexus, emissary veins. Now internal acoustic meatus, temporal bone. This is again total petrous temporal, temporal, between temporal and occipital. So temporal bone, this part is basically temporal bone, and this is basically the sphenoid bone. So temporal bone, it is a thick bone through which very important nerves are passing. So internal acoustic meatus, the facial nerve is passing, the glossopharyngeal nerve is passing, and 9, 10th, 11th, 12th nerves, they are passing. Jugular is passing, and again the internal carotid. So temporal is a thick bone through which pittus temporal internal carotid coming inside, then temporal bone, facial and vestibulocochlear nerve, then stylomastid foramina, facial exit is there. Between temporal and occipital, the jugular foramina is there. This has got an important vein which is passing, coming out, that is internal jugular vein. Along with these, the three nerves, they are exiting, 9th, 10th, 11th. Glossopharyngeal accessory. You can see here, this is the jugular vein and three nerves. So what is the important part of 11th axis nerve? The spinal root is coming inside from the foramen magnum. This is the, now we have come to the medulla. Foramen pons medulla. This is the end of the brain. Midbrain pons medulla. From here, spinal cord, cervical one vertebra will be coming. So spinal cord, the spinal root, you can see spinal root of accessory is coming from C1, first cervical. This is the medulla. From there it is joining, and these are the cranial part of 11th nerve. It is coming inside from the main foramen magnum and coming out along with these two friends. This is 9th nerve, this is 10th nerve, and they exit out of this. This would have gone, if this would have gone like this would have been shortcut. But instead of that, they are coming. The nerves are protected by in this manner. So 9, 10th, 11th becoming internal. So foramen magnum is the last major aperture. Anterior and posterior spinal artery, spinal cord has to come. Medulla oblongata is there, spinal axis is there, temporal membrane, apical ligament, don't die. And last, another one is 12th nerve. 9, 10th, 11th is there, and 12th nerve, there is hypoglossal canal, very small hypoglossal canal. You can see this was the jugular, and here is a small. So the brain is sitting in this, and small nerves, these just the wiring, electric wires, they are covered through passing out of the bones for a protection to shock, for injuries, and these surfaces, they are protecting, the like canals, they are passing out of this and supplying to the different organs.